Okay, welcome everybody to another session of the Disability Networking Zone 2020. My pleasure is it to introduce 4 speakers to you today, and they will tell us a little bit about their journey with HIV and AIDS and disability, and what the COVID epidemic can maybe learn from it. One of our speakers is particularly very much involved in the COVID epidemic and how people with disabilities are integrated. So the speakers that I have here is Professor Hellen Myezwa, who is the head of the School of Therapeutical Science at the University of Witwatersrand, Wits University. I have also Professor Saul Cobbing, who is a lecturer at the University of KwaZulu-Natal, Department of Physiotherapy. And with me I also have Zain Bulbulia, who is, and I have to look this up, the Director of Special Programs in Gauteng, special programs with particular inclusion of people with disabilities. And he is currently leading the COVID-19 disability response and is one of the major players that makes sure that people with disabilities are included. Now, before I give the word to Professor Hellen Myezwa, I would like to just set the scene. So, everyone knows the COVID epidemic is a new thing for us, and dealing with it is a new thing. And there are things that we can learn from other epidemics. And for us here in Southern Africa, it is particularly the HIV epidemic that we can learn from. And very early in the HIV epidemic, we did not see inclusion of disability on any kind of scale. We were very ignorant to the fact that there are people with disabilities who can also be infected with HIV, or who might even be specifically vulnerable to HIV and its impact. And there was advocacy, there was science around disability and HIV that highlighted the vulnerability, but also potential solution on what is needed in order to include people with disability and provide access. Vice versa, the people living with HIV, including those on a long-term treatment, are also experiencing disabling conditions of all sorts. And Hellen and Saul are going to explain us that more. So that we even need to think about that side of HIV management in the long term. So over the last 10, 15 years, we have learned how to handle one epidemic, HIV, and how we should include disability into that. And today, we're having a similar scenario where we have a new epidemic that we don't know. We don't have treatment for it yet, but we do know that people with disabilities can be infected with the virus as well, and maybe specifically vulnerable to the impact of the epidemic and also its larger lockdown stages in different countries. Vice versa, long-term infection with COVID, or overcoming acute stages of COVID-19 infection, may cause conditions that require rehabilitation. And again, we maybe want to learn from the HIV epidemic. Now, with these words, I would like to hand over to Professor Hellen Myezwa, who will share with us a little bit about how we discovered that long-term living with HIV comes also with disabling effects. Up to you.
Thank you very much, Jill. Just trying to see if I can find, yes. Thank you very much, Jill. Yes, as Jill has said, my name is Hellen Myezwa, and I'm a trained physiotherapist. I've been working in disability and have been a clinician before, so basically been qualified for over 35 years. And I thought, let me share the journey a little bit from the point of view of my experience with HIV and how I parallel it with the current COVID pandemic. One of the things that strikes me is how, if you look at the pandemic for HIV and you look at the pandemic for COVID, they are both conditions that are caused by a virus. And this is a critical issue of importance for all of us, because in both cases, we have no idea of the cure. We have no idea of the mutational aspect of the two viruses. And therefore, we are dealing with an unknown, more so for COVID than for HIV. And in the beginning with HIV, the pandemic started and there was a lot of death. And you know that COVID is similar. We've had quite a lot of death, and we've increasingly began to understand the impact of COVID on the human body. But one of the things that is common is that initially the known effects of COVID on the human being have not really been defined, particularly from a rehabilitation and disability point of view. And that was exactly the same with HIV in the beginning. And what we found is when we interfaced with people living with HIV, we didn't know quite where to begin. And so locating the effects of the condition became very important from the philosophy of rehabilitation. And so we looked at the different frameworks that we have used in normal rehabilitation, and found that we could actually apply these to HIV. And this is how it all began. And we started looking at the ICF, and which is the International Classification of Function. And this helped us to say, what are the impairments? What are the issues that we see in the acute phase? And just like COVID, as you hear people describing shortness of breath, fatigue, pain, inability to mobilize, those are the issues that one would speak about impairment. With HIV, it was a different story. The impairments were vast, because unlike COVID, so far we know that COVID does impact the respiratory system more than anything else, but it also does impact other systems, but we don't know yet. And it was exactly the same with HIV. And in the beginning, people would say, no, HIV doesn't cross the blood-brain barrier. And then later there was evidence to show this. And I'm seeing the same pattern happening with COVID, where we actually don't know to what extent it does impact the various body systems. So that is the first thing we can learn from HIV, is that we need to classify all these different impacts of HIV at an impairment level. And then what that would lead us to is to understand the impact on the disability and functional level. And this would be across time. So as COVID is acute, the same as with HIV, we first could describe it in the acute phase. And we have a number of papers which I'm sure we'll be able to upload on the resource platform for this networking. And then after that, we had to define what were the disabling effects of HIV. And it was quite interesting that in the beginning, if you went to policy meetings, or you went to clinical meetings, people would say, where is your evidence? And I'm sure that Professor Jill will also attest to that, because we sat in many meetings where people would say to us, yes, we hear you, but we don't believe you because you do not have the evidence to show that HIV does have disabling effects. And so using the ICF and tools that were developed around the ICF, initially we used the raw ICF, and we defined, we measured, we looked at the different types of disability, the different impairments, the different participation restrictions. So if a person has impairments and then has disability, naturally the next follow-on according to the ICF is the participation restriction. And so that is an area that I think we can learn in this COVID response from the HIV response, that first, let's define our problem. Let's understudy it. Let's have a look at what is actually happening to the patient. In the biomedical approach, a lot of our colleagues will say, test, treat, and then, I'm sure they're fine. But that's not necessarily true, because the disability may be acute, it may be long-lasting. We have no clue at the moment in terms of COVID. And there are groups who have began to outline the impact of COVID in terms of its outcomes. But all the papers I've looked at up to now are only looking at medical outcomes, and nobody is looking to say, what is the residual problem that the individual remains with? And that is the disability that we need to define. Another learning aspect, I think, that comes from this is it starts to show up what are the health inequalities that exist because of the position that people who are COVID positive and are COVID survivors find themselves in. What is available for them in terms of support? What is available in terms of related accessibility, affordability, and appropriateness of the support system, as well as the treatment that they may receive? And I think in terms of disability, what is actually being done for these people in terms of supporting them returning to their previous level of function, or even being able to maintain it. A third area is that we found with HIV is that in understanding all these areas, us particularly in the medical fraternity and the healthcare fraternity and even the social care fraternity tended to think we need to assess and document. But we did not think of actually involving people who are living with HIV in the beginning of the pandemic. And this is a learning point that we should get right from the outset in terms of dealing with people who have survived COVID, and also in the prevention aspects of social distancing, etc. We're still using the top-down approach, telling people. Have we asked people, why is it that people are not socially distancing? And we need to bring in other expertise in terms of social reengineering. Just yesterday, I walked through the Faculty of Health Sciences, and in my mind, health science students must be able to understand social distancing. And I'm telling you, I counted 10 groups of students sitting half a meter or less away from each other, no masks on, and having a chat. And I went to each individual person and said, is this what you describe as social distancing? And they just looked at me. And to me, it's because we just tell people. So we must go back to the basic principles of awareness. How do we actually increase awareness? How do we involve people? How do we empower people? How do we make sure they take agency? And I think the communities in particular are are not being involved enough. So when you see on social media children throwing masks around and dancing, or communities not taking any notice at all, I think we need to ask ourselves, like we did with HIV, did we take the right approach to prevention of HIV? And we learned many lessons, and I think there's a lot of literature for us to go back to, and we shouldn't reinvent the wheel. We know what we had to do with HIV to correct matters. We should also do the same with COVID. That's a third point that I would like to emphasize in terms of what we learned and what happened with HIV and how it mirrors COVID. And in that respect, it underscores the the question of ensuring that we have a multidisciplinary team. And I know that at policy level, this has been excellent in our setting in South Africa, where they've involved various professions, right from business across. However, in the space of managing and creating a care model for COVID, we must not forget to ensure that we have a multidisciplinary effort and a transdisciplinary effort as well that ensures that we include everybody. The other area is the need for long-term care. And this has been an area where we, in the space of HIV, going back to understanding the different disabilities and understanding the effect of HIV, it was not a static journey. There was definitely growth in our knowledge of understanding that, yes, a person can have disability, but it changes. And colleagues of ours in the West did a lot of research on this and came up with the HDQ, which is the HIV Disability Questionnaire. And in that process, they defined a concept that they called episodic disability. So what kind of disability does COVID have? That's something we need to look at. And how does it behave? That is something we need to look at, and look at it across a lifespan. So in the beginning, COVID did not affect children. Now we know that it does. With HIV, we have very different, we had very different understanding from the effect of HIV on children. And for some reason, across the decades of HIV, we skipped the adolescent and we rushed straight to the adult. But actually now that more research is being done, there's clarity that there are disabling effects on children, there are disabling effects that are unique to adolescents, and there are disabling effects that are unique to adults. And therefore, that's another learning point in terms of disability. It's understanding the type of disability, it's understanding the behavior of the disability, it's understanding the changes across the lifespan in terms of disability for COVID that one can learn from HIV. I think I'll stop there because I could go on the whole day, but I think that gives you an overview, and I'm sure that my colleague, Professor Saul Cobbing, will add to what I've shared with you. Thank you.
Go ahead, Jill.
Wait a second. Thank you so much, Professor Myezwa. So you have given us there at least like 3 or 4 research topics, I think, that that we need to apply for new grants, I think. So it is for everybody who's more interested in Professor Myezwa's work, please also visit the WITS website on the School of Therapeutic Science. I'm sure you find her vast publications on the topic to learn from. It's a pleasure to introduce now Professor Saul Cobbing, who is going to tell us a little bit more, okay, if there are disabling effects, so what? In resource-rich setting, yeah, we have plenty of different types of therapists that can help us in the system. But what about us here in Africa, particularly in maybe resource more constrained settings? What could be potential solutions we should think about? Over to you, Mr. Cobbing.
Thank you, Jill, and thanks to Helen as well for setting the scene. Firstly, for those people listening who don't exactly know what rehabilitation is, often people think of drug rehabilitation or something along those lines, but essentially rehabilitation is any kind of intervention or set of exercises that helps address people's functional limitations or impairment or disability, something they're experiencing either acutely or in the long term. And, I'm glad Helen touched on the multidisciplinary approach because, we look very broadly at all the systems in the body. And exactly like she said, over time, we found out how HIV really does have an impact across the whole body. And rehab has a big role to play in mitigating these issues. But like Jill said, in resource poor countries, or where inequality is particularly stark, you find that people don't have access to any rehabilitation or very limited rehabilitation. And that's certainly what we find in South Africa, where sadly, you know, we have the most unequal society on earth, probably. And when you find there are no physiotherapists, occupational therapists, speech therapists, audiologists, psychologists, you know, anyone who delivers rehab services, when there aren't any such professionals, or people living with disability cannot actually access any of those people for various reasons, we have to look at alternative approaches to rehabilitation. And that's something we've looked into in our environment, sort of resource poor rural environments, and found that approaches like home-based rehabilitation, where you actually go to people's homes and deliver the rehab in their homes or close to their homes, or get closer than the nearest hospital. So, for example, working through local clinics. But again, you're often left with the problem of not having enough professionals who are involved in rehab. And that's where we have to look at task shifting interventions, where we train community-based workers to deliver rehab services, either basic services which they can do on their own, or more complex services through supervision or collaboration with the professional. And that really brings me to what we can apply from the HIV epidemic to this new COVID-19 epidemic. What's been interesting in South Africa certainly is how important the community response has been in the corona response. So, you know, all this mass testing that's going on, a lot of the people involved with that are indeed community care workers who in a sense are learning new tasks to do the testing and be involved in the education response to coronavirus, which has been quite heartening to see. But again, like Helen said, I don't think anyone's really thinking of rehab at this stage. We're thinking very medical, you know, which is understandable. Let's test people. Those people are sick, let's get them medical services. But what we're starting to see in other countries, certainly we can learn a lot, but also now in South Africa, that it's not as simple as that if you just get corona and then recover, that everything's going to be okay. And, you know, I close experience of this, a very close friend and colleague of mine became infected with coronavirus, ended up very ill in hospital, and thankfully he recovered and was sent home. But weeks later, he's still feeling, you know, he's not completely better. He's got a lot of fatigue, weakness, reduced exercise tolerance. You know, there were issues with taste and swallowing and things like this. And looking at some of the early research coming out, we're seeing, you know, an increased risk of things like stroke, for example. You know, there's a definite link with stroke, with fatigue, with myopathy, and some other conditions. And I think Helen's right. The longer this is going to be with us, and we think it's going to be with us for years, the more impairments we're going to see across the human body. And, you know, rehab really needs to be made central to the response. Linking it to HIV, of course, you know, I think most people watching will know South Africa is the highest number of people living with HIV. And early indications, you know, South Africa's got over 1,000 people who've died, and they've looked at some of the sort of correlations, and they're finding that people with HIV are at more risk of both being infected and sadly from dying. But I don't think they have enough data yet to look at, you know, whether people are, you know, what their viral load, that kind of thing. But I think more of a worry than just are people getting infected is access to services. You know, if we're hearing in a lot of hospitals, everything's being pushed towards treating people with coronavirus, and the worry is people will, you know, certainly people who have disability and HIV might not get the services they need, and that is hugely problematic. And again, it just raises the need to have alternative access to things like rehabilitation, to things like, you know, people being able to collect their tablets, not have to go to a hospital, you know, very much community responses, because across the world where we've seen there's great inequality, even in countries like America, you know, the people who are poorer and more vulnerable, we're including people of color and people with disability, are at a higher risk of both becoming ill and having a worse sort of prognosis. So we've got to pick that up early. Rehab's got to get involved. We've got to have a voice, working very closely with people living with disabilities, working with people with HIV, and finding what's the kind of best response to make sure they aren't left behind in this pandemic. Thanks, Jill.
Thank you so much, Mr. Cobbing. And yes, you have highlighted as well, it's not only about the short-term acute treatment, that is about the long-term. And yes, home-based care or even community-based rehabilitation and home-based rehabilitation can help us. Now, I found it interesting that you mentioned the community-based rehabilitation worker. And one thing I want to add, and what Saul also knows, is people with disabilities can be part of their team, and sometimes they are crucial as peer educators and peer supporters, and just as people who sensitize others to the needs of people with disabilities in such a pandemic. And thanks for pointing out that they can easily be forgotten when attention goes to an emergency. We had HIV back then, we're having COVID now. Now, we are very lucky to have one of these outstanding individuals here. And Zain, please also introduce yourself and who you are and what is special about you in particular in terms of people with disabilities. And Zain is going to share with us and how he is currently ensuring that people with disabilities are not left behind in the COVID response. And some of that is also very similar to what we found early in the HIV response, where things were collided first about how are people with disabilities affected, and then how must they be included, and what is it that they need. And yes, people with disabilities themselves can be at the forefront of that solution. To you, Zain.
Thank you, Professor Jill, and it's my honor to be with the other two professors, Saul and Hellen. It's just an honor to be with you guys on this webinar and to share the experience. And my main focus is basically looking at disability rights in the entire Gauteng as a province, working with civil societies, but also working with various other partners, as well as looking at what departments are doing according to their annual performance plans and all of that. Since COVID has started and announced that the lockdown by the president on 27th of March this year, there was no mention about people with disabilities and COVID. We heard lots of stories, we heard lots of insights around older people and children and various others, and purely people with disabilities was left out. It's exactly what has happened with HIV and AIDS. And this particular program, I then decided we need to do something as a province, we need to do something as individuals, we need to do something as activists. And I got a group of good colleagues from other departments which I pulled together. I brought activists together, and I brought business partners together. And we said, how are we going to look at COVID-19, disability, and including all other illnesses that goes with it? And nevertheless, HIV and AIDS popped up immediately. Just to share a quick story, last week, we had one of the disabled guys from an organization in the Val that has HIV, he's a paraplegic, and was rushed to hospital. And obviously they treated him for diarrhea. Sent back home, got very ill at the center again, sent back to the hospital, and he passed away. After doing the test and various others, HIV and COVID. the mere fact that he had to come back to the center because that's where he lives, we had to have the place demopped, cleaned out, fogged, and everything. So the challenge is not only with people with disabilities, but it lies in communities. It lies in protective workshops. It lies in centers where people with disabilities are all the time. And one of the greatest problems that we found is that there's no proper PPE that was provided to people with disabilities. No education around care of your assistive device. So whether you're a wheelchair user or using crutches or various other assistive devices to get your modes of movement, and the care of that, and where the pandemic sits and the virus sits on those equipments that you're sitting on, those equipments that you're basically using. So yes, those are one of the issues that we find, and I'm glad to hear there's quite a bit of research and papers that's going around academically, but we're working on the ground and we've seen it happen. And being working in the call center as well, we pick up that 99% of those calls that have come through are basically asking for food. So people with disabilities, besides a disability, they don't have anything to eat. So how do you, what plays first? Do you get PPE first? Do you get food first? Or what attention do you give to a person with a disability? The past 3 days, it has been extremely cold. Nights have been going down to 0.2s and -3 and 4 and whatever. People with disabilities suffer quite a bit in terms of the way they live. So one of the things is we then got this team together. We partnered with them. They've collected close to about 2 million rand worth of groceries, which we donated since the lockdown has started. We then clustered people into various groupings, and we've been maintaining for the past 3 months a monthly grocery pack so that they could have a good meal, keep warm. Last week, we just delivered some blankets so that people can keep warm. So disability, besides having a disability, getting the virus, then having HIV and AIDS. So you're sitting with 3 different things. How do you get rehabilitated? And I hear the story about rehabilitation and breathing and all of that. It's about survival. Half of them can't even afford to get to a rehabilitation center or see a specialist or just see a OT or a physio or just go to a medical doctor to see. Hospitals are turning them away because the priority one is to look at COVID patients. How do we do the test? What do we do with children with disabilities? So kids with autism, high autism, kids that have to wear a mask and can't put a mask on for more than 5 minutes. So all of these things we have to look at. How did COVID really impact on disability? And it's huge. I think one of the papers that you guys should have looking at is children with severe disabilities and this COVID pandemic. What research is going around there? I've sat in quite a bit of webinars with learners with special education needs and them getting back to school and the readiness. People are, in terms of the sanitizers, skin irritations and various others. So you got to look at it's huge. It's just not out there. It's come over from China into South Africa and we're living. So the challenges are there. How do we combat these challenges? So we need the medical teams. We need people on the ground. We need people to assist us. We need people to come out and give us their knowledge of how to go about this. The other big problem that we find is when people collect their social grants. So you have older persons and you have people with disabilities, both vulnerable, no social distancing. How do they collect their pensions? What do they do thereafter when they get their pensions? The first stop is doing the grocery shopping and things like that. So the pandemic is really hitting the most vulnerable. And we definitely need to see how we could shift that into a much more positive way. Education is needed, awareness is needed, but we need the education and awareness to the vernacular languages. We speak too much English. The debates, everything, the president, when he talks, it's just in English. And we find that the most vulnerable people are at the grassroots. They don't even understand. They don't even understand the method of wearing a mask and what is the reason of wearing a mask, looking at the droplets and various others. It's quite difficult. So what we've done in Soweto, we've started a peer counseling group with an organization called Human Care, which is sponsored by the Japanese government, and they're doing awareness around accessible homes. We've changed the program around to say, you've got the peer counselors, let's train you up in terms of the awareness of COVID, and then work with all the disabled people within that area. They've got a group of already 150 people with disabilities, which they basically training up, and it's train the trainer, and how do they take that down? Again, COVID is a stigma. So you have HIV and AIDS, and now you got COVID. What happens? For most of the people that I've engaged with, just knowing that they're positive is more of a stigma than having AIDS. And this is what we're picking up. So the stigma is there. They don't want to get out. They don't want to talk about it. And life just carries on. And life cannot be normal. We need to put measures in place. We need the academics to come and assist us and show us how we could work together and join hands and take this program forward. We could learn from all the research work around HIV and AIDS and the care and the treatment and all of that. And how do we then just include it to make that COVID works in line with that so that we have the same care for people with disabilities. My main concern also is assistive devices, care for assistive devices. And this is something that we need to talk about. People are just normally getting pushed around with their wheelchairs. You don't know who's positive that's pushing your chair. Are you being infected or not? So yes, Professor Jill, we've got a lot to learn. We've got a lot to pick up from there. I put the challenge to Professor Hellen and Professor Saul so that we can work together and see how we could take this program forward. Thanks.
Thank you so much, Zain, for sharing that. It is really interesting. And as you all three highlighted, we are at the beginning of the epidemic, understanding there's so many parallels we can learn from HIV. And yes, again, we can learn it from HIV, I think, as well. We academics and you guys on the ground, we need to work together to make, to push things forward and ensure people with disabilities are not left behind. Now with this, I will close the session for the recording purpose. Again, everyone who is watching us, you can see more of these video clips from the DNZ on the ADIRA website, which is on the South African Medical Research Council, the websites for the it's a networking website called Advancing Disability Inclusive Research in Africa, so ADIRA. You can watch there more and future work. And Zain, we will take you up with your challenge of collaborating and finding out more and finding solutions. I'm sure you're going to hear from us via email. Thank you so much, everybody.
Thank you.